Pleural effusion. Comprehensive overview. It is defined as an abnormal accumulation of fluid in the pleural space, which can impair lung function and cause respiratory distress. So, what are the type of pleural effusion? They are broadly classified into transudate pleural effusion, result from systemic factor affecting pleural fluid balance. Example are congestive heart failure, that is CHF, nephrotic syndrome because of kidney, cirrhosis of liver. So, second is a exudative pleural effusion. It is caused by local factors such as inflammation, infection, or malignancy. Example are tuberculosis, which is very common in our country, pneumonia, which is common in children, malignancy is common in old age, and pulmonary embolism after surgery, pancreatitis. Special types are chylothorax, in which lymphatic leakage, common in trauma, malignancy, hemothorax, blood in the pleural space, trauma, rupture, aortic aneurysm, emphysema, pus in the pleural space. It can be bacterial infection, post-surgical infection, malignant pleural effusion, metastatic cancer affecting pleura. Cardiac causes are CSF, congestive heart failure, pericarditis. Pulmonary causes are pneumonia, tuberculosis, pulmonary embolism, lung malignancy. Renal causes are nephrotic syndrome, renal failure, hepatic cirrhosis with ascites, that is hydrothorax. Autoimmune causes are rheumatoid arthritis, lupus pleuritis, trauma, chest injury, post-surgical. Now, in a pathophysiology and pathogenesis, transudate formation, increased hydrostatic pressure in CSF or decreased oncotic pressure in nephrotic syndrome, liver diseases lead to fluid leakage. In exudative formation, inflammatory and infectious processes lead to increased vascular permeability, protein leakage, and cytokine mediated recruitment of immune cells. Lymphatic dysfunction, it is a chylothorax, or chylothorax result from lymphatic obstruction or trauma. Hemodynamic changes, pulmonary embolism may increase pleural capillary permeability, leading to pleural effusion. So, pathology, gross examination, clear transudate versus cloudy turbidate, that is exudate fluid. Microscopic features, increased neutrophils, acute infection, lymphocyte predominant, it is in tuberculosis and malignancy, malignant cell in cancer, fibrinous deposit in chronic effusion. Now let's talk about the clinical manifestation. The symptoms are dyspnea, which is a shortness of breath, pleuritic chest pain. There is a sharp pain on deep inspiration, dry cough, fever, night sweat in infection, tuberculosis and malignancy. Now let's talk about the sign. Diminished breath sound on auscultation, decreased tactile vocal fremitus, dullness on percussion, pleuritic friction rub occasionally. Diagnostic evaluation. First is imaging or radiology, X-ray, chest X-ray, blunting of costophrenic angle, that is a CP angle, fluid meniscus sign. In ultrasound, detect small effusion, guides thoracentesis. In CT scan, it identifies loculated effusion, underlying malignancy, emphysema. In thoracentesis, pleural fluid analysis, light criteria which differentiate transudate fluid from exudate. Gram stain, culture, infectious cause, cytology, malignant cell, ADA, that is adenosine deaminase. In tuberculosis, additional tests are BNP for congestive heart failure, ANA or RF for autoimmune, D-dimer for pulmonary embolism. Treatment and management. Transudate effusion. Treat the underlying cause. For example, diuretic for congestive heart failure, albumin for nephrotic syndrome. Therapeutic treatment is thoracentesis for symptom relief, exudative effusion, infectious, emphysema or TB, IV antibiotic, drainage, fibrinolytics, malignant effusion, pleurodesis, indwelling, rular catheter, chylothorax, dietary modification, low fat, high MCT diet, surgical repair, hemothorax, chest tube drainage, surgery if necessary. Now in preventive strategy, first is a vaccination of pneumococcal and influenza to prevent the parapneumonic effusion, early treatment of infection like tuberculosis and pneumonia, lifestyle modification in heart failure, renal and liver disease management, future prospective, biomarkers for early diagnosis, molecular diagnosis for differentiating benign versus malignant effusion. Targeted therapy. Immunotherapy in malignant pleural effusion, minimally invasive technique, video assisted thoracoscopy surgery, that is called VATS, for pleural biopsy and drainage, advancement in pleural fluid management, long-term pleural catheter for palliative care in recurrent effusion. Thank you.